Good afternoon, everyone. We're just going to give it a couple of more minutes just to allow for more people to join, and then we'll start our webinar. Okay, so let's get started. Hi, everyone, and welcome to today's webinar on maintaining pulmonary health after total laryngectomy. My name is Daniela Esteves, and I am the UK lead head and neck specialist nurse at Atos Medical. Our presenter for today is Alana Kelly, who is the clinical manager for Atos Medical UK. And also with us today is Phoebe Benta, our head of clinical events, who will be in the background ensuring all runs smoothly during our webinar today. Very quickly, and just to get through some formalities, please be aware that by providing a virtual forum for this discussion, Atos Medical is not providing medical advice. The answers provided are not guidelines or endorsements. We will start with the presentation from Alana, who is a speech and language therapist and has extensive clinical experience and expertise working with laryngectomy patients, having worked in America and also in the NHS as a specialist head and neck speech and language therapist, team lead at St. George's Hospital in London. Today's webinar is the first of a three-part educational webinar series. And during this webinar, we will be presenting responses from 1,800 laryngectomized patients worldwide to better understand their pulmonary issues. Alana will present research on factors impacting mucus production and discuss solutions and improvements. So to get started, Alana, over to you.
Thanks, Daniela. Sorry, I had to take myself on mute there. Welcome to the webinar. As Daniela said, we'll be talking through the issues around pulmonary health after total laryngectomy. And just quickly to run through the overview, the slides that I'll be presenting. The first chapter will be on pulmonary health within laryngectomized patients. And the second chapter will go into factors which impact their pulmonary health. And within the third, we'll discuss how an HME can be used to manage and improve pulmonary health, and then talk about some of those changes during COVID in chapter 4, before finally becoming back to a discussion on a case study, which I'll present in just a moment. Next slide. So Daniela mentioned, back one slide, please, Phoebe. Thank you. So as Daniela mentioned, this is the first of a three-part educational webinar series. In November 2018, Atos Medical commissioned the largest laryngectomy patient study ever, and I'll be referring to some of this data throughout the presentation. There were three key themes or sort of key problem areas that came out of the study, and the first was pulmonary health and problems around mucus. The second was skin irritation and problems around continual skin irritation within most patients. And the third was around laryngectomies having problems being active. Today we'll be taking a deep dive into the first topic, which is pulmonary health. A little on the study itself. It was intended to add understanding of patient needs. It was conducted by an external company called Red Associates, who are a recognized global anthropology and sociology consultants, and they also work with large pharmaceutical companies. It was also in association with the Netherlands Cancer Institute, which is an internationally recognized center of scientific and clinical laryngectomy expertise. It was preceded by, the survey itself was preceded by some ethnographic research in the spring of 2018. And this was done through a series of face-to-face interviews with 18 patients and 18 healthcare professionals in 4 different countries. And then the survey itself that went out to patients was based on the most relevant questions that came out of this ethnographic research. Next slide. The way the survey was conducted was online, and it was through the ATOS medical database. And in total, 1,734 patients participated in 9 different countries. There was a 21% response rate, which is quite high. The majority were men, and this is an accurate representation of the laryngectomy population based on gender. More men being laryngectomies than women. Again, some of the data I'll talk through today is taken from this study. And we also have a booklet available with all the relevant data, which we'll provide to you after the webinar. Okay. Again, so the first chapter we'll be looking at is pulmonary health. We know that patients experience problems with mucus and their daily routines, and it has a big impact and effect on their lives. So if we first take a look at a case study example that was taken from the study, and this is similar to quite a lot of patients out there. So this is Simon, and he struggles with mucus and finding routines that help him to improve his pulmonary health. He's a 63-year-old man, and he was diagnosed with a T3 hypopharyngeal cancer and had a partial pharyngectomy, total laryngectomy, primary TEP and puncture and voice prosthesis placement with post-op radiotherapy. He began wearing a laryngectomy tube straight after surgery, as well as an HME on day 1. And after his skin healed, he was fitted with an adhesive and continued to wear an HME and just kind of got on with things as they were. He was successful with wearing an HME during the day, but not so much at night. He had goals really to find a good routine after a total laryngectomy, to go back out again and to do things like play bridge with his friends. He also wanted to reduce the amount of mucus and forced expectorations he had because he continued to experience these throughout his rehabilitation. The barriers to him sort of achieving these goals were that he finds it uncomfortable when attention is drawn to his stoma. He doesn't like wiping away mucus from it, and his adhesive comes loose quite often because of the mucus that gets trapped underneath it. So as a result, he stays in most of the time, and he's had to take early retirement after his total laryngectomy. So again, this is a case study with a specific example, but quite similar to a lot of patients that are out there. Next slide. And we can see within the qualitative research that Simon is one of many who struggle with mucus in daily routines. So these are a few other examples of patients with a range of pulmonary problems that were taken from the survey. And when trying to get back to everyday life, these patients continued to face persistent problems with mucus, their base plates, and this had a negative impact on socializing in daily life. You can see that one of them said that he had to remove his HME to cough 15 times a day. So this interrupts the pulmonary rehab cycle. Another said that he takes quite a long time, an hour each morning, to prepare his stoma for the day. And another one said that there are times when he was socializing, he was at a wedding where he had to leave owing to a coughing fit, and it was humiliating. Next slide. The clinical evidence that's out there also correlates with the survey data to show that pulmonary problems exist in almost all patients, negatively impacting and affecting their daily lives. So this early research was done in patients not using HMEs. So it was in 1990 when HMEs weren't available. But it showed that pulmonary issues such as mucus production were present in almost all patients, so about 98% of patients. But data today shows that even if patients are using HMEs, 89% of these patients still report issues with mucus. And this is data from the quantitative survey. And it's interesting to note that respondents, as I said before, the survey went out to Atos medical patients. So these patients are typically quite highly compliant with HME usage. 95% of them actually reported using an HME. But even still, these highly compliant patients are the one who use an HME. When I say compliant, I mean use an HME 24/7. So even those who use an HME and use it most of the time still have pulmonary issues and problems with mucus. Next slide. And problems with pulmonary health also impact daily life. So within the research, we can see here that 69% of patients have mucus flare-ups during meals or social occasions, such as that example that I mentioned on a few slides back. And 35% of patients also avoid socializing owing to the mucus problems that they have. We know that laryngectomies are at risk for depression, decreased socialization, and isolation post-surgery as it is. So addressing the reasons behind this is critical. Next slide. Clinical evidence also reports pulmonary issues correlate to most other issues and might be an underlying cause for many issues related to quality of life. This was a study from 2020 called The Interaction of Functional and Participational Issues on Quality of Life After Total Laryngectomy. And it looked at 1,700 patients and it found a high correlation between pulmonary issues and other themes, such as limitations in daily activity, poor sleep, reported overall vulnerability. And all of these issues really come back to relating to a patient's poor pulmonary health. Next slide. Next slide. Okay. An interesting finding of the survey was that even though patients have problems, they don't talk much about it. They get used to the problems with mucus that they have, almost like wearing a watch. You may notice it when you're wearing it initially, but you stop noticing over time. Sometimes they often think that this is just the way it's going to be and that things won't improve. And so this is what they have to cope with. So the study itself found that these patients have these hidden problems that they don't report and they often don't speak to their clinicians about. There's a high degree of trust in their clinicians. They go to them for advice, but still they have these problems that they don't report for whatever reason. These are the global findings, and you can see here that there's a high level of trust with the doctor, the consultant, and the speech pathologist. And then on the next slide, we can see the UK results. So again, a very high degree of trust in the clinician. And in the UK, where most of the follow-up, the voice prosthesis changes, they're done by the speech pathologist, there's an even higher degree of trust. But still, these hidden problems, or for whatever reason, these problems, patients don't speak to their clinicians about. Next slide. So what impacts laryngectomy pulmonary health? We go into a little bit of detail right now into that. Pulmonary health is influenced by a patient's overall health, the comorbidities that they have, and the consequence, of course, of being a neck breather. We still have about 56% of patients who are smokers, laryngectomy patients who are smokers, and then the underlying comorbidities that influence their lung health in this population are typically around COPD, chronic bronchitis. The anatomy of being a neck breather obviously has a huge impact on their overall pulmonary health. And this is because of the loss of the upper airway functions, such as humidification, resistance, and filtration. And of course, that impacts pulmonary health and mucus. So smoking has reduced overall. In the UK, there's great smoking cessation programs, but the average age of diagnosis in laryngectomy is still around 65 years. So these patients are typically still part of that smoking generation. The overall health profile of laryngectomized patients still remains the same. So it's that median age of about 65 and mostly men. And still the majority are smokers, or there's a combination of alcohol and smoking as well in these patients. Next slide. So we mentioned COPD and shortness of breath being some of the common comorbidities in laryngectomized patients. And the evidence shows us that about 81% of patients have chronic COPD, so quite a high number. And 56% can become breathless, so short of breath with exercise. And 38% can even become breathless with a small amount of exercise like quick walking or going up a small hill. Other underlying problems can include lung dysplasia and potentially a history of aspiration pneumonia prior to their laryngectomy owing to a dysphagia. So how do we manage these comorbidities? Well, environmental changes like smoking cessation or medical management or therapy, and sometimes this can be long-term and chronic, like oxygen therapy, nebulizers, mucolytics, or potentially some physiotherapy. There's been some evidence within using EMST or expiratory muscle strength trainers as well in some patients to improve their overall lung health. Next slide. And obviously one of the biggest impacts on pulmonary health is the change of the physiology of the airway after laryngectomy. So within the normal pulmonary system, you have optimal conditions. You have a temperature of 37 degrees, which is body temperature, 100% relative humidity. We breathe in through our nose, which gives heat, moisturizes the air, filters the air as well, and it provides a degree of resistance, which helps to prevent atelectasis. There's filtration through the nose, and there's multiple layer of protection, really to prevent anything from entering the lungs. And then this is in comparison to an open stoma, where you have a significant drop in the temperature and humidity before it enters the lungs. You really have no to little resistance at all, and significantly reduced filtration as well. So big changes in comparison to breathing through the upper airway. Okay, and evidence shows us that humidification, breathing resistance, and filtration of the air are really essential for pulmonary health. The humidification component is to keep the cilia working, to prevent mucus from trapping. Resistance needs to be present for PEEP and to prevent atelectasis or airway collapse. And filtration is necessary to prevent viruses and bacteria from entering the airways. The conditioning of inspired air is mostly important for the mucosa of the airway, which really need a moist and a warm environment to stay healthy. It's related to that optimal body temperature and relative humidity of 100%. And below that, you can get impairment of mucosa, or mucosal function can become impaired. The airway mucosa, as you can see here, has 3 layers: the cell layer, the aqueous layer, and the gel layer. And the cilia cells have cilia, or little hairs, and they actively move in a stroke or kind of wave-like pattern. And they help to move mucus, which contains dust and bacteria, out towards the pharynx. And at this point, from the lungs up to the pharynx, at this point, it can be coughed out or coughed up and swallowed. And this is part of the mucociliary transport system and is mucociliary clearance. So in a healthy individual, the temperature and humidity are such that the cilia move well, they function well, and they sweep everything out. If any of the layers, the gel, the aqueous, or the cell layer, which you can see here in more detail in the diagram on the right, if any of those layers are altered, the function suffers. Next slide. Back one slide, sorry. So the cold and dry air, what happens with cold and dry air is it irritates and eventually damages the mucosa and the trachea and bronchi, especially the cilia, and it slows them down, so it prevents them from beating as fast as they need to, and it can damage them. And ultimately, you can have cilia death, they can die. Because of that irritation, more mucus is produced, and mucus becomes stiffer and more viscous, and you get mucus trapping then. And so there's less transport and movement of this mucus up and out, and also the dust and the microorganisms are swept out less as well. And this is the reason why so many laryngectomies have what we call forced expectorations to try and get that mucus out. There's also a big increased risk for infections as well with cilia damage. Okay. Next to our video. So this is a video showing cells in different stages obtained by biopsies. And first you can see here that we have tracheal cells with a loss of cilia. So most of the cilia here aren't functioning. Second, we have ciliated cells with and without movement. So the big patch in the middle there aren't moving, but everything else is moving pretty well. And the third, this is how we want things to be. These are healthy ciliated cells with great coordinated movement. And there you can see that sweeping-like motion. And Phoebe, if you could play that again, please, so we can get a real feel for what's happening. Thank you. So again, we have loss of cilia. So what we don't want to see. We have better function here because we have most cilia working, but a patch in the middle where they're not. And in the final example, it's moving like normal. And these are actually within laryngectomized patients. And we know that HME results in better cilia movement because you get the atmosphere that's required to promote healthy pulmonary function. So another important function of the upper airway is that's lost when you're breathing through a patient's breathing through a tracheostoma is filtration. And filtration helps to protect from microorganisms and pathogens, bacteria, viruses, and also particulate matter like smoke or pollen. The upper airway acts as a filter through a combination of methods that sort of increase the effect on one another. And one is an increase in surface area. Another is how the air flows through, the manipulation of air through the nose. And the little hairs in the nose actually increase the surface area and also to help capture particles. The turbinates that are there are ridges that kind of protrude in the nose. They increase the surface area and they also help to direct the airflow, which adds resistance. And then there's a mucosa inside the nose that produce mucus, and they have the mucosa in the nose also has cilia as well. Particles are captured in the mucus and transported with the help of the cilia towards the pharynx, where again, everything can either be coughed out or it can be swallowed. Okay, next slide. So a normal breathing filtration is performed by the upper airways and mostly the nose. So when you're breathing through an open stoma, clearly filtration will be reduced, significantly reduced, as it no longer takes place in the upper airways. Therefore, laryngectomized patients are expected to have a much higher deposition of particles in the lower airways, and this will increase the risk of pulmonary complaints and also respiratory infections, as I mentioned before. When patients breathe through an HME, they have a logical barrier for any airborne material. Potentially, if a patient needs more protection as well, an HME combined with something like an electrostatic filter, like the Provox Micron, which has a very high filtration efficiency of higher than 99% for bacteria and viruses and airborne particles, can be effective as well. The Micron itself has an effective filtration for exhaled air, so it also provides protection to the surroundings. Next slide. That takes us to how HMEs work and how they can be used to manage and improve pulmonary health. So if we talk first about how an HME does work, it has three main properties: humidification, filtration, and resistance. So it provides those three essential properties that the loss of the upper airway, that are removed with the loss of the upper airway. And as we've seen during COVID, another very important component of an HME is a degree of containment as well. And they work during exhalation. There's a collection of heat and humidity by retention of water in the foam. So you breathe out, the patient breathes out, the retention of water is collected in the foam, and then they inhale and they return that heat and humidity back to their lungs. The HME foam itself is treated with calcium chloride, so it helps to retain moisture within the foam. There's also some degree of filtering within an HME. So standard HME filters between about 50 to 70%. So a non-HMEF is what I mean. And all HMEs as well partially reinstall breathing resistance. Next slide. An optimal HME has high humidification performance and comfortable breathing resistance and is easy to speak with. So you can see here sort of a side view of an HME. The foam itself, as I mentioned, is impregnated with calcium chloride, which is a hygroscopic salt, which aids in moisture retention. And this is an ATOS HME here that we have a diagram of. The density of the foam core itself can vary. So the denser the core, the more the humidification and resistance for breathing. The more porous the core, the less resistance there is for breathing. The foam should encompass, as you can see it does here, the entire inside of the cassette, and this is to maximize the HME benefits such as resistance, humidification, and temperature. And here you can see on the all the way to the right there an example of two different foam types side by side. So on the right you have the ATOS Luna, and the extra moist is on the left. And you can note the different size pores and the different heights of the foam, and both attribute towards resistance and humidification performance levels. And so there's always a trade-off really when you're using one HME over another. And this is between the level of filtration, resistance, and humidification performance provided to the patient. And this is really why it's so important that there's a range of HMEs to suit the needs of the patient and to fit, whatever situation they're in, really, whether it's resting or exercise or sleep, because different types of HMEs do different things. Okay, this is the micron, and just to touch on what the micron does, as filtration has been clearly highlighted during COVID as being very, very important for neck breathers. Therefore, it's been repeatedly recommended in the medical guidance to use something like an HMEF, which is an HME with a very effective filter. This is the Provox Micron, and it is an HMEF with a filtration efficiency of more than 99%. This slide gives the performance figures for the range of HMEs that we have, and it shows the different levels of filtration, resistance, and humidification. And remember, the lower the figure for moisture loss, the higher the humidification performance. So the better the humidification will be. And in terms of resistance, this is measured in what we call hectopascals. And this is an international unit for measuring atmospheric or barometric pressure. And you can see here that the micron, and it's interesting to mention as we had a question on our webinar on Tuesday about this, the micron actually has the same level of resistance as the extra moist. It's often misleading because it looks bigger. So there's often a thought that it has a higher level of resistance, but it has the same level of resistance. But you can see here, there is a difference between the filtration levels, the breathing resistance, and humidification, which is why it's important to choose the right HME for the right situation and what the patient is doing. Next slide. So clinical evidence shows us that HME use is important not only during the day, but at night. So back to our case study, Simon, who really just uses it during the day. So he's not going to get the full effect or full benefit on his pulmonary health. And BN in 2010 showed us that patients should be compliant or using an HME 24/7 to get a positive effect of HME use. Those who used an HME 24/7 or compliantly had a significant reduction in coughs and forced expectorations, but they had to be using the HME day and night. So this is some evidence that supports compliant HME use. And we know that when patients are compliant, they have significant reductions in pulmonary symptoms. This shows that as well, that they have a reduction in coughing and forced expectorations. This study also shows us, Perilla from 2015, that there is an effect just within a short amount of time. In this study, there was a positive impact, a significant impact actually, after only 2 weeks with compliant HME use. After only 2 weeks, there was a reduction in forced expectorations and coughing. It's interesting to note that this continues to improve until up to 12 weeks where the effects plateau. And this is a great study when you're speaking to a patient about what to expect when they're using an HME and when they can expect to see improvements. It does happen quite quickly. This shows about within 2 weeks. Next slide. Okay. So as discussed, it's well established in the literature that 24/7 compliance or day and night use of an HME prevents complications and improves outcomes. Multiple studies here that show that some of the improved outcomes when using an HME all the time or reduced infections. It can be more cost effective. There is an increase in ciliated cells and that sort of impact on the mucociliary transport system. There's reduced crusting, better and more fluent TE speech, better sleep, and there's a reduction in the need to use external humidifiers and nebulizers as well. Next slide. So going back to the nebulizer point, so it's interesting, when we looked at the survey data, we found that about 20% of patients used a nebulizer twice or more a day within Europe and in the US. If you look at the next slide, which has the information from the UK, so this is UK specific data here, and we can see that it doubles to more than 40%. And it's interesting to note, we know patients don't like being dependent on equipment. We know from the evidence that using an HME all the time can reduce the need for things like nebulizer treatments. So it's probably something that we should be striving towards in the UK to get our patients less reliant on machines and equipment. And there's also in literature, we know that there's an importance, we find an importance for using an HME early on after surgery. So clinical evidence shows significantly less coughing and sleeping issues with an HME right after surgery in comparison to something like an external humidifier or trachea mask. So this is data from Merrill 2012, and it compared using an HME to a trachea mask right after surgery, and it found better compliance, reduction in pulmonary and sleeping problems, and also higher in patient and nurse satisfaction as well. So positive benefits of using an HME versus a trachea mask. Another example of the important use of HME is Foreman from 2016, and this showed significantly fewer complications when using an HME right after surgery in comparison to a trachea mask. And this was recorded with less adverse events, mucus plugs, in comparison to an HME. Next slide. Okay. This was an article that was published by Ebersol very recently, and it was comparing HMEs again with an external humidifier, and it concluded that HMEs were superior in reducing, again, an incidence of mucus plugs and that immediate postoperative phase for laryngectomies. Very strong evidence there. Despite the significant benefits, though, of using HMEs as a rehabilitation method, whether it's sort of early on postoperatively or in the long term, we do see that clinical studies show that the compliance rate still can be low. So a few examples here, about 77% when Brooke looked in 2013, and going back a little bit further, ACRA staff showed us that the compliance rate was only 53% in 1996. So it's getting better, but we still have some room to move and some progress to make. One of the reasons why patients sometimes aren't compliant is because of skin irritation, and that was highlighted in the Brooke article. Next slide. Another reason could be product confusion. Patients identify different reasons for using HMEs, which isn't always supported by clinical rationale. So patients make HMEs fit into their lifestyle, and this is what we found in the survey, the quantitative survey. Some patients thought they were only for speaking. Some patients thought they were better to use when they were exercising. Some just wanted them to sort of hide their stoma itself. And some thought that they were, again, for sleeping and only for sleeping. So a misunderstanding and product confusion as well. Okay, so if we talk a little bit more about COVID and pulmonary health during COVID, just to quickly touch on coronavirus itself. We know that it's a variant of SARS, which stands for severe acute respiratory syndrome. 15% of common colds are coronavirus. And the difference with COVID or coronavirus is even though it has a lower mortality rate, it's much more contagious, which is the reason why it's so dangerous. So roughly 2 to 10% of people infected require mechanical ventilation. And when patients are admitted into intensive care, the mortality rate is about 50%. It poses a risk to patients as well as healthcare professionals, especially in laryngectomised or tracheostomized patients who have an open and exposed airway. These patients also are usually complicated due to their history of respiratory issues. They're prone to atelectasis or to loss of airway resistance. Sometimes they have comorbidities such as diabetes or obesity or lung conditions that can impact the severity of COVID, their COVID presentation. There's still discussion about how coronavirus is transmitted, and it's clear that it's transmitted by droplets. There's 2 studies suggesting that it can also be transmitted by aerosols. Both droplets and aerosols can be generated through different ways. Already there, within breathing, there's a creation of some droplets and aerosols. Speaking produces slightly more. Coughing generates lots of droplets and aerosols, and sneezing even more still. There's many different factors influencing how far virus particles can spread. And in general, one can say that the quicker the spread of the particle, the further they go. So due to gravity, droplets fall towards the ground, but aerosols can hang in the air for some time. And for COVID or the novel coronavirus, it's been shown that aerosols can stay in the air for up to 3 hours. So due to that hanging in the air and their small size, aerosols can be moved around very easily. And one study has shown that coronavirus and the aerosols itself can be found in the air even 4 meters away from patients. It increases the infectivity of COVID. So there's been lots of challenges and considerations for the protection of healthcare professionals who look after laryngectomized patients. So we have to ensure staff have adequate PPE during any procedures when looking after laryngectomies and tracheostomies. In terms of postoperative care, there are some extra considerations as well. Staff have to be educated on the risk of AGPs and how to limit them. And these patients can often become severely unwell. Safe suctioning has to be considered, which is always an AGP. There have been, most evidence says to use an HME and use an HME with effective filtration, and to encourage self-suctioning and self-stoma care in some patients as well. We've seen changes in outpatient clinics where there's been a deferral, especially in the beginning of not all non-urgent visits. Things are changing now, but we've also seen a big push to use telemedicine and telephone screenings, which has been a learning curve for a lot of clinicians. Obviously, then there's the considerations of PPE and the room cleaning and the downtime that's required between the rooms. And in a home and in community, patients were encouraged to shield in the beginning and also advised to wear protective neck coverings and use things like HMEs and HMEFs. And this has seen an increase in the use of these throughout COVID. Patients also really needed to take care for hygienic stoma care and making sure that they were washing their hands even more frequently when they were looking after their stoma. So how should these patients be protected? Again, some international guidance suggests the use of HMEFs and base plates not only in the community, but also in the hospital. So we've seen immediately post-operatively, there's been some change where adhesives are being used instead of laryngectomy tubes to create a complete seal. I know some hospitals as well have begun using the micron immediately post-operatively as well. And if you go back to thinking about that resistance, it's no different than the extra moist, and it's best to use it straight away so that patients don't get used to having no resistance at all. This is a great picture here taken from Dr. Brooks' book he just published last month, and it shows the practical application of a face mask over the stoma, and how to adapt that. Patients are also suggested to wear a face mask over their nose and mouth, because coronavirus can obviously be picked up through the nose and mouth as well. Okay, next slide. Okay, so what can be done to improve pulmonary health? Well, if we go back to Simon and to his goals and barriers, so just a reminder about what they were. His goal was to find a routine, to go back out again, to play bridge, to meet his friends. He really wanted to reduce the amount of mucus and forced expectorations he had. But he was having difficulty achieving this goal because he really finds it uncomfortable to be socializing when he's drawing attention to his stoma. Still has lots of problems with mucus, so has to wipe it away. And then his base plate loosens as well. So he ends up staying at home most of the time. So I thought a good way to discuss this case study would be to bring in Daniela. Daniela introduced herself at the beginning. She's our UK lead nurse, and she is very experienced working with laryngectomies and tracheostomy patients in the community, and will help to answer some of these questions we have about Simon and how we can help him. If you go to the next slide, Phoebe. So first, if we want to sort of have a look at what the possible reasons are for Simon and patients like Simon not being HME compliant. So we know that he wears an HME most of the day, but he doesn't wear an HME at night. And evidence supports this, that compliance or that 24/7 usage is still lower than we would like it to be. So if we talk a little bit about why we think it is that he's struggling to wear an HME day and night, Daniela, based on your experience and what you've seen with patients potentially like Simon, why do you think that might be?
So some patients who don't wear a HME at night, one of the main reasons is when they use base plates is to give the skin a rest overnight. So other reasons would be when patients have comorbidities such as COPD, and as you said on the presentation, more than 80% of laryngectomized patients have COPD. They might find that when laying down, the breathing resistance from breathing through an HME, they find that they can't tolerate that, so they have to remove it to catch their breath. And sometimes patients, when it's early on after surgery, they are frightened to cough in the night and not be able to remove the HME in time. So I think these are the main reasons that I found that patients have for not using a HME overnight.
Okay, and can you share some of the solutions for these issues that you've worked through with some of the patients in your caseload?
Yes, so I think the first thing we need to do is to look at the patient's skincare routine to determine why don't they use a HME overnight. If they have skin irritation, what is the cause for the skin irritation? Are they using the right base plate for them? Can they use, for example, Luna, as you mentioned, that has a base plate that will aid the healing of the skin overnight? Or can they keep the base plate that they use during the day, can they keep it overnight instead of going through the process of changing it? That might be causing the irritation as well. So it's important to understand their routine in that sense. And also, if the issue is the resistance, we could work on promoting a habituation to that resistance. So if the patient, when they lay down, if they find that breathing resistance is uncomfortable, we can start with using it for small periods of time during the day or earlier on before they get into bed, so they get used to that increased breathing resistance and they are comfortable using it when they go to bed. And also help patients understand why are we trying to help them use the HME overnight, helping them understand that using HME 24/7, as the research has shown us, will help with reducing the coughing, reducing forced expectorations, which in Simon's case was his initial goal.
absolutely, setting those expectations,
Mm-hmm.
sort of, sort of going on the journey with them is so important, isn't it, as well?
Yeah,
Thank you.
definitely.
Okay. So if we move to the next slide, pose another question here. So again, Simon wears the same kind of HME most day and most of the days, and usually nothing at night. So a few questions I have for you here. Do you think Simon knows when to use what product and why? And have you seen this in your caseload as well? And does he know that there are different alternatives to what he uses?
Yeah, that's an interesting one because, as you mentioned before, it's important to understand why do patients use, what is their understanding for using HMEs. I've got a patient who thinks that she puts her HME on so she can speak on the phone. So having understanding why do they think the HME is for and working with that is very important. And also, yeah, so often I do give patients the HMAs and have the patient to look at them and understand why does that one have bigger pores and why does that one look a little bit thicker, and the rationale from using one against the other. I think it's quite important that patients do understand that what their options are and why it's important that they do understand them so they get better outcomes and can cope with using the HMA for the situation that they're in.
Totally agree. I think even, as a clinician, I didn't really have a full grasp or understanding until I actually took an HME and tried breathing through it myself or broke it apart and really studied the difference in the resistance or the difference in the foam and the impact that had on resistance and humidification.
Yeah.
So do you think he would be helped by switching HMEs based
Uh,
on the need that he has?
yeah, I mean, from his history, sounds like he's only using one type. It doesn't specify which one. Um, but so in Simon's case, we know his issue is coughing, forced expectorations, and we would have to work on why does he not use a HME overnight. So if his issue is the skin, we could obviously work on the base plate use, as I mentioned earlier. But if the resistance is the issue, we could definitely help with providing with helping him use a HME that will help retain moisture, and that way he will be able to manage his secretions better. And obviously, if a resistance is an issue, because as we've seen in the graph before, the extra moist, for example, has a higher breathing resistance than the extra flow, for example. We can start with an HME with lower breathing resistance during the night and progressively increase the amount of time that he uses that HME for, and slowly start to use something a little bit that will retain more moisture, but it will also have a breathing resistance a little bit higher. So work on that habituation. And that is also very important to take into account, especially for those patients who leave hospital with a stoma protector or a bib, and we want to help them start using HMEs. If we start with a extra moist or a Luna straight away, that rapid change in breathing resistance, patients don't often cope very well with it. So starting with something that is easier to breathe through and increasing the amount of time they're breathing through it, and then working on going into something that will provide more moisture retention and help with secretions management. Definitely.
Yeah. Sometimes I know it's important as well to take into account comorbidities. So if someone does have, significant underlying COPD, starting with something postoperatively like an extra flow can be quite helpful for them to sort of get used to using an HME in general. Last question on this slide. Do you ever find that some patients just can't tolerate an HME? So do we have enough HMEs, for every situation?
Yeah, I mean, I've already mentioned briefly those patients who had laryngectomy many years ago and have been using the bib or the square foam over their stoma. They they find it really hard to start using HMEs, but then they, as you said early on the presentation, they think that having issues with coughing and secretions is just a part of it. So it's easy to get into that. Oh, this is just how I am now. So I find it very hard to try to make them understand that it can be better, but maybe having a HME with even lower breathing resistance for those patients, and also for the other patients who already use HMEs, but they can't go up a hill without removing the HME due to not being able to catch their breath, and that goes with the comorbidities that you said just now. So patient has COPD. They often do tell me that they have to remove their HME to catch their breath.
Yeah, absolutely. And I think, we know that HME engineering and performance has improved over time. You can see an example here in this picture of some of the innovations that ATOS has made over the years with regards to our own HMEs. And now there's a wider range of HMEs to fit the situation, but we still have some patients, like you said, Daniela, that need to remove their HME for whatever reason, for exercise. They can't tolerate certain base plates as well. We find that quite a lot at the time. So we know that we need to do more as manufacturers. Some patients still don't have the right solution. So at ATOS, we're definitely continuing to innovate and provide better solutions based on the patient feedback that we've been presenting just now, and the research that we've been doing into patient needs as well. So thank you. Okay. So we know using HME at night will improve his mucus. We've seen the research and evidence to show that. But we also know that it can't quite match nasal humidification or normal humidification or breathing. So, what does good look like in an HME? Based on that, do you think that Simon could be helped by using an HME that provides higher humidification, even though it can't match nasal breathing?
Definitely. You can see clearly that his secretion management is not ideal. And if we are working on having that optimal breathing resistance, that optimal humidification and warmth of the air by keeping an HME on during the day, if he doesn't use it at night, then all that work that is done during the day is not carried on overnight. But if, as I said before, if the breathing resistance is an issue, we need to work on that. But if his goal is to reduce mucus production, it's important that he understands the benefit of using HME that will provide higher humidification. So he sticks to the plan. So setting expectations for him, making sure he understands the plan of action, so he's more likely to stick to it. And also making him understand that it won't be an immediate improvement, and it might take maybe up to a couple of weeks before he starts seeing reduction in coughing and forced expectorations.
Last slide, thank you. So one problem that was highlighted in this study was that patients don't often talk about their problems, and they often say they're doing fine, and we don't know as clinicians that they're actually having any problems with mucus. They're hidden. So how do you think we can help patients like Simon to discuss their pulmonary health in order to reach their goals, which is the goal he identified, so important to him?
I think patients often do think, they don't want to bother their clinician, and they're doing okay, so there's nothing, they should be complaining about. And often when you ask patient, how are you doing? How have you been? They will say, yeah, I'm okay, I've been fine, I'm coping all right, I'm doing well, I'm talking fine, all those things. But it's not until you start asking specific questions, such as, how often do you have to go away and clean your stoma? How often do you have to clean your valve? Do you wake up coughing in the night? Do you have to nebulize or use a suction? That's when we start asking those questions. That's when we start getting answers to the real issues in terms of pulmonary health and the problems they might be facing and not talking about it. So I think it's important to talk about these things and ask specific questions like that, so patients feel like they should be talking about it.
Thank you. Maybe last slide, just to summarize some of the points there. So we know there's a need to improve HME compliance and HME performance to improve patients' pulmonary health and quality of life, as we saw in the research, and as Daniela was just discussing. We still see a high percentage of patients reporting problems with mucus. So it was 89% who have to clean mucus away from their stoma, several times a day in the research that we showed. And we know that pulmonary issues can be improved by managing factors such as lifestyle and comorbidities, but also through compliant or 24/7 HME use. The benefits of HME during rehabilitation are clear, but clinical evidence still shows us that compliance rates are lower than we'd like. So there's a need to address pulmonary issues by improving HME compliance and also performance. So as a manufacturer, we also still have a job to do to make things better for patients, not only with HMEs, but also with base plates, I'd say also. COVID has definitely increased our awareness for humidification and filtration needs. And we've seen an increased usage in the HMEs, the Micron, and also just generally more HMEs being used in general, which is a great positive effect that would be a good trend to continue. We're going to go into some questions now.
Thank you, Alana. Thank you for presenting, and now we will move on to the questions and answers. We've had a few questions posted prior to this webinar, and actually already have another one posted just now. But if you have any questions now, please use the Q&A function on the screen, and we will do our best to get them answered in the next few minutes. I'll be keeping an eye on them. So the question we've had from Kirsty, Alana, is why is a modified face mask over the stoma needed if a patient is using an HME?
Good question. Patients ask this as well, but it is to reduce the amount of direct touching to the HME that they would be doing. So if they are occluding their HME to talk while they're out and about, wearing a fluid resistant mask on the top of that would give a higher degree of protection.
Thank you, Alana. And another question that we've had, and I'll try to ask two in one, is the first one is, when is it best to introduce an HME after laryngectomy surgery? And have there been any issues with patients that have used Optiderm immediately post-op?
I think you touched on this as well. I think introducing an HME straight away is what's best. Anytime you allow a patient to get used to a lower level of resistance, it's much harder then to introduce it later on, and they may struggle to get used or to sort of reintroduce a resistance down the line as an outpatient. So there's been an improvement in the UK in using HMEs immediately post-operatively, which has been great to see. The Optiderm is ideal as a base plate as well to use post-operatively. It's hydrocolloid, and it provides this sort of moist wound healing environment, which creates a barrier, which is almost like an artificial scab, really, and it creates a viral and a bacterial border to the wound as well, and it kind of supports the body's ability to heal. It's intended for use post-operatively, and it is safe to put directly on top of the suture line and also the staples as well.
Yeah, I remember from my days in ICU where we had patients immediately post-op from abdominal surgery and laparotomies. They would have the stoma bag and the dressings that were hydrocolloid directly over the wound, so that makes sense.
Yeah,
and
it's commonly used in wound care as well, hydrocolloid. Yeah. So,
and one last question before we wrap up is, has HME use changed during COVID?
Definitely. I think I alluded to that in that last slide there as well, to say that there's certainly been an increased use of HMEs in the laryngectomy population, increased use in HMEFs, the Micron, to provide that extra protection for laryngectomies when they're going out, so they can feel safe as well. We've also seen this translate into the tracheostomy population, which has been great, because that population uses HMEs even less than the laryngectomy population, where it's become the gold standard.
Brilliant. Well, thank you, Alana. That brings us to the end of our presentation and questions and answers. And I would like to thank everyone so much for joining this webinar, and thank you to Alana for presenting. And we have recorded this webinar, so if you know someone who wasn't able to attend or think there might be some of your team members that might find this beneficial, please feel free to share it with them. We appreciate all of you taking your time today to join us, and we wish you all a nice rest of your day. Stay safe and stay well.
Bye, everybody. Thanks so much for joining.
Bye.